Greetings from the EULAR 2025 Congress. My name is Victoria Sadovic. I'm Professor Assistant at the University of Medicine and Pharmacy Nicolae Timițeanu in Moldova. And our guest today is Professor Daniel Clauw, Professor in Anesthesiology at the University of Michigan. Good afternoon, Professor, and thank you for accepting our invitation.
Well, thanks for having me.
We just had an exciting session about fibromyalgia. Is it or not an autoimmune disease? So, Professor Clauw, please, could you briefly explain how our understanding of fibromyalgia evolved over the last decade?
Well, interestingly enough, fibromyalgia a long time ago was called fibrositis. So initially, when the term was first introduced, we actually did think that it must be some kind of diffuse inflammation, i.e. itis. And then the research showed that there really wasn't any inflammation in the muscles or in any of the areas that we could, where people were having pain in fibromyalgia. So the name was formally changed from fibrositis to fibromyalgia, algia meaning pain, itis meaning inflammation. But interestingly enough, in the last 5 to 10 years, it's become clear that there is it's a primed immune system in conditions like fibromyalgia in that, again, I wouldn't in any way call it an autoimmune disease. That was what the debate was about. But I do agree that the pendulum is swinging back a little bit to recognizing that there might be subclinical inflammation in fibromyalgia. It may be that the immune system is primed in people with conditions like fibromyalgia so that when they experience different types of stress, that they have more of an immune response than again, someone that doesn't have that sort of primed immune system. So I thought it was a really good discussion. Again, I think it's still not a correct term to use it to call it an autoimmune disease, in part because I think that what that means to many people is to use the drugs we use in rheumatology to treat autoimmune diseases, and everyone seemed to agree that those drugs didn't work, including Andreas Goebel that was debating against me.
Yeah, right. And then speaking about the treatment then, how would clinicians find the right balance when choosing the treatment for the right patient, and how to balance between pharmacological and non-pharmacological treatment?
Yeah, the non-pharmacologic therapies for chronic pain in general and for fibromyalgia in particular work well, but it's not easy to get patients to do them. So certainly like physical activity, one of the things that I think was helpful in my practice a long time ago is that I learned not to use the word exercise, and instead I just encouraged people to become more active, and that wasn't as threatening to them to become more active. But I think that it's best to start by getting people moving and getting them sleeping better and trying to do different types of techniques to manage their stress. But the evidence does suggest that a lot of therapies that we used to be fairly dismissive of, things like acupuncture, acupressure, yoga, tai chi, all sorts of different therapies that used to be called alternative or complementary are really now the evidence base suggests they actually can work quite well. And now our challenge is to figure out how to integrate those therapies into our practice. Of course, we're always going to be using drugs when they work, but for conditions like fibromyalgia, the mainstay of treatment is really a lot of the different non-drug therapies, the integrative therapies, especially those that get people moving and getting them sleeping better.
Thank you, Professor, for this complex answer. And then looking to the future, what do you think that would be the future of fibromyalgia? Which studies are the most promising, or what are we expecting?
I think the future of fibromyalgia is like the future of most of medicine. We're trying to move in more of a precision medicine direction, in that we realize, again, that there's some people with fibromyalgia that have really prominent psychological factors and have had difficult traumatic experiences, and there now are data suggesting that there's specific types of cognitive behavioral therapy that might be really effective for that subset of people. Maybe there is a subset that has an inflammatory component. We don't know yet how to recognize that or how to treat it, but maybe a subset has an inflammatory component. So I think that just like with other diseases, I think we're going to take this whole, glob of people that we call fibromyalgia now and start to say, okay, this subset of them maybe has more of this cause and is going to respond more to this treatment. But that's work that we're doing more broadly in the field of chronic pain, is really taking these treatments that work in maybe 1 out of 3 people. Acupuncture, acupressure would be a good example. and figuring out, well, like, who do they work in and who should we really give these to preferentially, rather than, unfortunately, what we do right now is just guess. It's like, oh, I'm just going to give acupuncture to this person, or I'm going to give yoga to this person, or I'm going to give cognitive behavioral therapy. And a lot of studies that are ongoing now are precision medicine studies to say this subset of people with fibromyalgia is probably going to respond to this treatment and this treatment, whereas they're not going to respond to these other treatments because that's not the right underlying mechanism for them.
Thank you very much. And thank you very much to everyone watching. Thank you, Professor, again for agreeing to this interview. And we wish you a great EULAR 2025 Congress ahead.
Thank you.